Denture stomatitis should be mentioned because it is often classified as a form of erythematous candidiasis, and some authors may use the term chronic atrophic candidiasis synonymously. This condition is characterized by varying degrees of erythema, sometimes accompanied by petechial hemorrhage localized to the denture-bearing areas of maxillary removal dental prosthesis. Although the clinical appearance can be striking, the process is rarely symptomatic. Usually, the patient admits to wearing the denture continuously, removing it only periodically to clean it. Whether this represents actual infection or simply a tissue response by the host um, remains controversial. The clinician should also rule out possibility that this reaction could be caused by improper design of the denture, which could cause unusual pressure to the mucosa on the mucosa. Allergy to the denture base or inadequate curing of the denture acrylic. Denture stomatitis, maxillary denture with complete palate vault associated with midline tissue hyperplasia. Denture stomatitis not associated with Candida albicans confined to the denture-bearing mucosa of the maxillary. Okay, albicans is often associated with this condition. Biopsy specimens of denture stomatitis seldom show Candida hyphae actually penetrating the keratin layer of the host epithelium. Therefore, this lesion does not meet one of the main defining criteria for the diagnosis, which is the host invasion of the organism. Furthermore, in the palatal mucosa and tissue contacting surface of the denture, if they are swabbed and separately streaked onto an agar slant of savor, savor, the denture typically shows much healthier colonization by yeast, much heavier colonization by yeast. Chronic hyperplastic candidiasis, which is a candida leukoplakia. Some patients with oral candidiasis, there may be a white patch that cannot be removed by scraping. In this case, the term is chronic hyperplastic candidiasis, the term to be used. This form of candidiasis is the least common and is also somewhat controversial. Some investigators believe that this condition simply represents candidiasis that is superimposed on the pre-existing leukoplakic lesion, a situation that may certainly exist at times. In some instances, however, the Candida organism alone may be capable of inducing a hyperkeratotic lesion. Such lesions are usually located in the anterior buccal mucosa and cannot clinically be distinguished from routine leukoplakia. The diagnosis is confirmed by the presence of hyphae and associated with lesion, and more importantly, by complete resolution of the lesion after antifungal therapy. Figure 6.12, you can see hyperplastic candidiasis. These diffuse white plaques uh, clinically appear as leukoplakia, but they actually represent an unusual presentation of hyperplastic candidiasis. And then in B, treatment with clotrimazole oral approaches show complete resolution of the white lesion within 2 weeks, essentially confirming the diagnosis of hyperplastic candidiasis. If any white mucosal alteration had persisted, a biopsy of the area would have been mandatory. Mucocutaneous candidiasis, severe oral candidiasis may also be seen as component of a relatively rare group of immunologic disorders known as mucocutaneous candidiasis. Several distinct immunologic dysfunctions have been identified, and the severity of the candida infection correlates with the severity of the immunologic defect. Most are sporadic, although an autosomal recessive pattern of inheritance. Okay. Albicans and mutations of the gene responding for producing the cytokine resulting mucocutaneous candidiasis. Mm. Después de las 9, ¿no? También, pero todo el mundo lo sacó. Interestingly, the candidal infection remains relatively superficial rather than disseminating throughout the body. Both the oral lesions and any cutaneous involvement usually presenting as rough, foul-smelling cutaneous plaques and nodules can be usually controlled with continuous use of relatively safe systemic antifungal drugs. As with any long-term antibiotic treatment, development of drug-resistant organisms can occur, however. ¿Qué está en la...? Oh. ¿Cortaste del grande? Thank you. The diagnosis of candidiasis is usually established by the clinical signs of conjunction with exfoliative cytology examination, although culture can definitely identify the organism of albicans. This process may not be practical in most office settings. The cytology findings should demonstrate the hyphal phase of the organism, and antifungal therapy can be then instituted. If the lesion is clinically suggestive of chronic hyperplastic candidiasis, but does not respond to antifungal therapy, then biopsies should be performed to rule out a possibility of candida superimposed on epithelial dysplasia, like on epithelial dysplasia, squamous cell carcinoma, or lichen planus. The definitive identification of the organism can be made by means of culture. A specimen for culture is obtained by rubbing a sterile cotton swab. 2 to 3 days incubation room temperature. Nystatin, $200,000 to $400,000, dissolved in 4 to 5 times a day for 10 to 14 days. So in the 1950s, the Pauline antibiotic nystatin was the first effective treatment for candidiasis. GI tract poorly absorbs nystatin, and the effectiveness depends on direct contact of the candidal organism. This necessitates multiple daily doses so that the yeasts are adequately exposed to the drug. Nystatin combined with triamcinolone, acetonide cream, or ointment can be applied topically and is effective for angular cheilitis that does not have a bacterial component. Amphotericin B is uh, restricted to do IV. Uh, it can be only used for life-threatening systemic fungal infections. These medications specifically became available as oral suspension for the management of oral candidiasis. Unfortunately, the interest in this formulation of the drug was scant, and it is no longer marketed in the United States. So, okay. Clotrimazole is a well-absorbed, must be administered several times each day. It is formulated as a pleasant-tasting approach. Ketoconazole, first antifungal drug that could be absorbed across the GI tract. But if it's to be taken more than 2 weeks, then a liver function study should be run because it's um, highly toxic to the liver. It has also been caused life-threatening arrhythmias if mixed with macrolides. And then fluconazoles, the triazoles, which are fluconazole, is well absorbed systemically, not required to be an acidic environment for its absorption. Uf, I'm sleepy. No sueño. No sueño.